So there you go. And tonight our presenter is Dr. Bradley Richlin. He's with Richlin Eye Associates in Beverly Hills, California, a fantastic clinician and someone that we all continually learn a lot from. And we can seek his guidance often. So Dr. Richlin, I'm going to turn the program over to you, and we look forward to learning something from you tonight.
Thank you, Richard. Also want to thank everyone for being in attendance. Hopefully you learned something. Hopefully I stretch your mind a little bit of what you think of when you think of sclerals and when to think of sclerals and how to manage dry eye maybe differently than you have been. When asked to do this lecture, one of the first things everyone thinks about for dry eye and sclerals are typically they go to an extreme. They think Stevens-Johnson syndrome, they think graft versus host, they think Sjogren syndrome. There's a lot of other patients out there that would really benefit from scleral lenses, and I kind of want to challenge everyone to think about those patients you might be missing in clinic every day. Think about those patients that would maybe benefited more in a hard lens than a soft for multiple reasons, and hopefully tonight I can shine some light on some things you're not thinking about. Our sponsors from Optimum Contimac, the material, the lenses that a lot of Blanchard lenses are made from, have Infinite. I like to bring that up every time. Infinite is one of our highest DK materials. It's our job to provide a fit and material to these patients that is the highest potential for success and also health. Having super high DK materials only aids in that approach, so I'm very happy that I can use Infinite when I order my Onefit lenses. So the Onefit family of scleral lenses is a pretty big family, and they're not all that different. That's something important. So from the Onefit A, specially designed for the Asian eye, the Onefit family, the Onefit Med, and now the Onefit Med Plus, slightly larger. This family is definitely a big family, but they're all very similar. So once you know how to fit one, you really kind of learn how to fit all of them. So don't think of this as a hindrance to, open the doors to this family of lenses, but think of it as a good thing. You can learn one lens and then know 3 other lens designs very closely. They line up in terms of the parameters, their attributes you can change. So once you learn one, you really learn a lot of them. And then tonight we're going to really focus on the Onefit Med and the Onefit Med Plus, which offer a few more customizable features for the medically indicated cornea. So with these 4 designs, you really get a lot of options of diameter. I believe in these 4 family lenses, you get over 10 different diameters, and that diameter selection is crucial for when you're fitting your patient. So just to kind of bring everyone together, and then we'll kind of jump into dry eye in a moment. When we're fitting the lens, the Onefit Med in particular, you want to think of 4 parameters, 4 important numbers, 4 important lens parameters that you're going to be ordering. One is sagittal height. We all know this one. How deep or shallow is the lens? Something that Onefit Med allows you to adjust, one of these fancy parameters, is the mid-peripheral value. Another edge we're allowed to adjust, parameter we're allowed to adjust, is the limbal clearance value. And then the last thing we can adjust is the edge, and that increases or decreases edge lift. So I think we're all really familiar with central sagittal height. I think we're all really familiar with edges, that we can change those, steep or flat. Bringing in the mid-peripheral value and limbal clearance value to adjust those all independently of each other really is why the Med and the Onefit Med Plus really are a fully customizable lens option that really gets you in the ballpark to fit any pathology that really walks in your door. And these changes between the Med and the Med Plus really is just diameter. So once you know the Med, you know the Med Plus just as well. So diameter is important, but why do we even think about diameter? We're thinking about diameter so often when we go to fit the patient first. This is the first lens they're going to put on the eye. You got to think of which diameter to pull. Think of diameter as the overall arching dome that's going to go over this patient's cornea, and we have to vault this cornea with this large dome. And you don't want to go too big, you don't want to go too small. Too big, too much vault in certain areas, you'll lose oxygen to the eye. Too shallow, if you get touched, that's even worse. You can cause other secondary things that you don't want to happen to the cornea by touching it. So you really want to be in that Goldilocks area, the perfect fit. So selection of diameter is important. And with the Onefit Med and Onefit Med Plus, it's really in this slide showing about the functional diameter of the lens. What really matters? The edges don't really matter. It's really the primary functional diameter of the lens that matters. And in the 15.6 to the 16.4, you can see how the actual functional diameter of that lens changes, really the dome of the lens before you start thinking about where it lands on the feet. So knowing the functional lens diameter kind of gives you an idea of how much of this lens is going to vault over the entire cornea. Looking at the Med versus the Med Plus, you can see that the Med Plus gives you the largest functional diameter for the lens, and not that much different than the Onefit Med. That means that the Med Plus and the Onefit Med family, really you can fit close to the same thing in a 16.4 Med and a 17.0 Med Plus. The biggest difference here is not really the functional diameter of the lens, but really it's the landing zone. How much extra foot do you have? And this is a really important thing because we're talking about zone width. So on the, for example, 15.6, you get a 2 millimeter landing zone width. That's how much of the lens is coming down on, 2 millimeters to weight onto the sclera. With the Onefit Med Plus, that 17 millimeter lens, you get an extra 0.8 millimeters. That's about 40% more landing to spread out the weight of the lens. And when we're talking about dry eye treatment in particular, and we'll come back to that in a moment, having a larger area to dissipate the weight of the lens really translates to a more comfortable fit, a more forgiving fit for you, and a more comfortable fit for the patient. So I like having these lens options where if I want to go big, I can, and it doesn't really change so many more aspects of the lens design. I can just move up from a 16.4 Med to a 17.0 Med Plus, and overall, the dome of that lens, the primary functional width has stayed almost the same, but now I'm getting a much wider landing zone to help with the fit, and that's so important. I love larger lenses, but those larger lenses are going to need some special attributes to make them fit well, and we'll talk about those in a moment. So kind of continuing on talking about how to fit Onefit Med and how to fit a scleral in general, you've got to vault the cornea. And then once you vault the cornea, you've got to make sure you don't have too much clearance in one area or another. The trial lenses that Onefit Med gives you are etched. The literal surface of that trial lens has a groove on it, a central groove and a peripheral groove. That central groove is really the mid-peripheral value, and that farther peripheral groove is the limbal value. So right away, lens on eye, you can see where the mid-peripheral area is and where the limbal area is, so that if you need to make an adjustment to a particular spot of the lens, when you look at it on the eye, you can say, wow, look at that. This zone, which is the limbal zone, looks like I have blanching here. Then when I go to order my lens, let me make that L zone, let me make that a little bit, give it a little bit more room so it doesn't have any touch or any blanching. Super important. If you have an OCT, as you can see in the black and white image on the top, you really see those etches, and coupled with the Onefit Med online tool and calculator, really you can get some fine-tuned lenses. The OCT image and the Onefit Med calculator online really are synergistic. They work really well together, and it's almost like cheating. You do not need an OCT, but if you have one, the fits go really well. But all you need is a slit lamp to get this done, because of their ingenious idea of etching the fronts of those lenses. And remember, that's the mid-peripheral center ring, and then the farther out ring, that's the limbal ring, as you can kind of see in that lower image. So how high or how much vault do you want in each of these zones? It's kind of important. So no one has an exact number for any one of these. But in terms of the central sagittal height, the M, L, and the edge, we can all agree on some general values. In essence, for me, myself, I like to be about 250 microns at initial insertion centrally. I like my mid-peripheral to be 150. my limbal zone at 100 microns, and my edge just to be flat against the sclera, not tight, not too loose, not blanching, not towing in, just a good even fit. I am on the thinner side of this range. From 250 to 300, I prefer 250. From 150 to 175, I prefer 150. I like a very thin post lens tear lake. The thinner that tear lake is, the more oxygen that can be delivered to the cornea. It's a more healthy fit. So I'm very picky about those zones, and I'm very glad to be linked up with a lens that allows me to adjust those zones. It's easy, it's nice to say, oh, I like to fit a very thin lens to have a very thin post lens tear reservoir to make sure I don't have too much impedance for oxygen to get to the cornea, but it's then harder to fit that lens without touch. Having a mid-peripheral zone I can adjust independent of any other zone, a limbal zone independent of any other zone, that's, you know, the most amazing feature. You can really fine-tune these lenses to be really healthy and to really get to where you want them to be. So landing zone, which we talked about in terms of the Onefit Med Plus versus the Onefit Med, the larger landing zones for me are very important because they are the reason why a fit succeeds or it fails. If you think about the landing zone and complications that can arise from errors in landing, that pretty much sums up every issue a patient has. Decentration of that lens can cause conjunctival prolapse, often inferior. Decentration of a lens can throw off the optics. They can be looking through a wedge that induces higher order astigmatism. A decentered lens can cause other issues. The flat edge can allow fluid to leak underneath, causing fogging. A flat edge can cause discomfort with the lid coming down or riding over the edge of the lens. A tight edge can cause hyperemia. The eye can look red over time. And really, if you think about all those issues, those are the biggest issues we have when we fit scleral lenses. Patients complain about red eyes, that they're fogging, that they're not comfortable, that they don't see as well. And that's a very important thing because this is just one aspect of the fit. And to get the fit just right, in order to land just right, in order to not have decentration, which then can cause these multitude of issues, you really want to be able to have options to center that lens, especially when it's a large lens. Why? Because our anatomical obstacles that we meet in the sclera are going to require that when you go a little bit larger. And what are those? Those are the extraocular muscle insertion points. So probably the last time you saw this was optometry school or CE or my last lecture, but just have to remember that the medial rectus, the inferior rectus, the lateral rectus, the superior rectus all insert at different areas around the limbus and at different distances from the limbus. Their insertion points cause differences in sagittal height of the sclera, a flatter or steeper elevation. So because we have 4 different insertion sites and different lengths corresponding to them, we can assume that a certain millimeter chord, you're going to have different toricities within that sclera. Really close and tight to the cornea, maybe 14 millimeters out, you might not have that many issues in a 14 millimeter lens. That's only 2 millimeters maybe beyond the limbus. But in a 17 millimeter lens, you do want to account for those differences. And that's why I like having quadrant specific designs available. And with the Onefit Med and the Onefit Med Plus, you do have them available, and I use them often. It's an important too. Having a lens that's not decentered really provides results to the patients. Let's look how. So this was a photo that I took of a lens before and after I made changes to the landing. This is not actually a quadrant specific. This is more a regular toric landing with the landing being different, flat and steep by a principal 90-degree meridian. So the first lens on eye, which was probably a good lens, probably could have left it there, was a 16.0 Onefit Med. The vault was 4,000. The power was a plus 4.87. The M and the L zones were standard, but the landing zone was a plus 25 flat in one meridian by 150 microns steep in the other. Looking at it on the eye, changing the toricity, adding a little bit of steepness in the vertical, flattening it out on the horizontal, going to a -200 in the vertical and flattening to a +75 in the horizontal, changing the L, adjusting the M, getting all those fancy parameters under my belt for this fit. If you look at the first image, you can see that it's decentered. There's a wedge. The superior lens is closer to the superior cornea than the inferior aspect of that lens is to cornea. In the second image, you can see a very even relationship between the lens and the cornea in terms of height. The first lens was probably okay, but long-term down the road, if there was superior touch, if it was writing, we'd probably get superior neovascularization of the cornea. And take a note here, with a change to M, with a change to L, with a change to the landing, I got this lens to fit better. And if you also look at the power came down as a result of the change to the M. Very fun how that works. Changing the M alters the base curve, it changes the power. So you get better vision, better centration, better health when you really pay attention to the lens on eye, and you have a lens that you can change. Sometimes you're stuck in a lens design that doesn't offer these parameter changes. So really, even though you see you need a change, if you can't make it, you're holding yourself back, and you don't have to do that if you use the Onefit Med. So just that was a really quick recap of fitting Onefit Med, sagittal height, mid-peripheral value, the limbal value, and the edge, and how it's important and why it's important to utilize those for a good fit. How does that tie in with dry eye, and what do I hope for you guys to take away from today? So dry eye is very complicated, and anyone who deals with dry eye understands that it's the lower back pain of optometry. It's always there. There's no perfect fix. Everyone has a little bit of it, but when it's there, it hurts, and it's annoying, and it's constant, and we have to figure out a way to get around it. So welcome to your 28-hour course on dry eye treatment and management. Hopefully everyone has some time cleared, because this is going to take a little while. Okay, so since I don't have 28 hours, I'm going to sum up a lot of what I've learned with treating dry eye with sclerals in the next, let's say, 20 minutes. But this slide is something that a lot of people have seen at dry eye lectures or continuing education, and you've probably seen this flow chart. It talks about why dry eye occurs. Why does epithelial keratitis occur? Why do patients feel burned? Why do they feel dry? Why are they getting annoyed? And I have a quick poll that's going to come up, and then we're going to continue going into this. And I want people to think about it. Going in really quick, go ahead and answer this poll for me. Do you consider scleral lenses to be a viable modality of treatment for ocular surface disease or dry eye? Do you believe what I'm going to tell you? We've got about 73% voted. The poll is closed. 98% of you said yes, 2% said no. So I'm working for you 2%ers out there right now to convince you why. You don't have to understand this whole flow chart and everything. You just have to know that sometimes our role is to get to the root cause of someone's dryness, and sometimes our role for a patient in our chair is to fix the issue that they're having at hand. I do not think you should skip the figuring out what the root cause is for a lot of your dry eye patients, talking about meds, talking about sleep patterns, talking about floppy iris and sleep apnea, and talking about sleeping with a fan on. There's a lot of reasons for dry eye in general, so don't forget about it. But this particular lecture is just going to talk about what do we do with it when it's in our chair, and how do we fit a scleral lens to help that patient. Because I really do think that a lot of patients are missed that could benefit in a scleral lens, and we just don't think about them daily. So who would benefit from scleral lenses and why? Who's going to pay for the scleral lens materials and fit charges that we ask for? And how do you best utilize the Onefit Med family of scleral lenses? So who would benefit? Well, post-RK, ectatic post-LASIK, PRK patients do well in hard lens optics. That's a given. Everyone knows that. If you see high astigmatism on your post-RK patient, I think that's when we think about scleral lenses. But don't forget about everyone else. Don't forget about the other patients out there that might benefit too. Now, corneal disease, keratoconus, or other primary corneal disease like pellucid marginal degeneration also do well in scleral lenses. Those patients are glued to their lenses. They can't see better out of anything else. Those patients you probably think of a lot when you think of a scleral lens. And then exposure keratitis from incomplete blinks, from excessive computer use, post-blepharoplasty, or log ophthalmos. Lots of reasons there to think about scleral lenses, but we often don't. So I think the bottom bullet point is where we often go in for our punctal plugs and our bandage contact lenses and our nighttime ointments, but we forget about scleral lenses. So think about that third one. The next time you see SPK, or next time you see persistent epithelial keratitis, the next time you see non-healing wounds, maybe think about scleral lenses, and this is why. They can provide a great relief to your patients, and I'll show you. Really quick, who do I think is not a potential scleral lens patient or candidate? Low refractive error patients with no corneal staining. To make that very clear, lessons I've learned the hard way, if a patient has a low refractive error, maybe not even in glasses or contacts, and they really don't have corneal staining, but they're your classic, oh, my eyes are a little dry or stingy, those are not your scleral lens patients that would really benefit. You really have to have corneal staining, some type of disease process present to go through the process of paying for time for fitting and the process of wearing and caring for a scleral lens. Not the run-of-the-mill, my eyes just feel dry patients, but the ones that are having corneal staining, those are the ones that I now think about, when before I was just thinking about my post-RK and my keratoconic patients. So let's go into a quick case example. So I've got a 72-year-old male. He's been told he sleeps with his eyes open. Chief complaint is distance vision can be better. Doesn't like to wear reading glasses, but they help. Has been told he has dry eye, uses preservative-free artificial tears as needed, and his eyes water daily. Refractive error, pretty low and unremarkable. Anterior segment, he's got 3+ corneal staining in both eyes, mild cataract, and back of the eye is normal. So not someone I would typically think about scleral right away. Normally I'd think about other advanced procedures like meibomian gland expression, punctal occlusion, and other copious lubrications, gel, ointments, etc. But for this particular patient, he had come back to me year after year, and this time I thought scleral lens. And let me show you what I did with him. So this is the front of his eye. So what's happening here, he sleeps with his eyes open, and even with nighttime ointment, even with punctal plugs, even with daytime gel tears, the patient presents looking like this. Probably a combination of time, but also lack of compliance. Now, I discussed with him that tackling his nighttime exposure was key. We've got to get his lids down, but to help him get better, to help him feel better, I asked him if he would try a scleral lens filled with water to saturate his eye that was feeling dry all day, and he went with it. By the way, showing patients photos like these really help with compliance to treatment, whether it's showing them their optic nerve and describing glaucoma or showing them corneal staining. With images like these, you really get to see and understand why treatment is important, and that conveys really well to patients. And also, just a quick disclaimer, when I'm in clinic every day and I take images, I don't always think about my lectures that I give in the future. So I apologize for some of my blurry images. I wish I could go back and take more photos of my patients to show you, and in the future, hopefully I'll remember to do so. So bear with me on some of these photos, but this was just the right eye. So what are we gonna do with him? We've got to fit him in a lens. For him, I chose a Onefit Med 16.0 millimeter lens based on his HVID, and had him wear the lens. The fit was pretty unremarkable. He had worn RGPs in the past. He knew insertion and removal, that was pretty quick for him. It took me 2 lenses to get the landing right, the vault where I wanted, and his keratitis improved very quickly. And now I wish, again, I took pictures more during the fit, but the next photo is after 3 months of wearing lenses and then coming in and removing the lens. Now, if you look closely, there's still some SPK there. This is after 3 months of wearing lenses. This is still only the right eye. I did not take a photo of the left eye. But for the most part, the eye has never been has never felt better. He loves the vision he gets out of it. He wears them full time now and wears over-the-counter reading glasses on top. Next year, I discussed with him that we can do a monovision fit or a multifocal vision fit for him. Then he's going to be really happy. But just a straightforward case of how full-time wear of scleral lenses can help resolve persistent epithelial defects or PEKs. And at the end of this whole fit, he said, why didn't we do this sooner? Why didn't I offer him this technology sooner? He said, when did this come out? And it was just my fault for never saying, do you want to go through the process of being fit to see well and to maybe even feel even better? At the end of our fit, I won't see him again until maybe next year. He had told me, by the way, I figured out a perfect combination of preservative-free saline and preservative-free artificial tears, and he found the perfect recipe that when he fills the lens bowl with, his eyes glide all day. They feel super slick. I've learned that from some of my patients that they find their own recipes of what to fill the lens bowl with, preservative-free tears and preservative-free saline. And he is one happy camper, kind of experimenting, having fun with his new vision that's sharper than ever and his new comfort. So who's going to pay for scleral lens materials and fit fees? This is an important question because it's really fun finding these new candidates in your chairs. You look over, you see high keratoconus, you look over, you see dry eye, you look over now and you think, okay, I'm going to fit him. But then you've got to do the hard part. Now you got to look over and say, okay, what insurance does he have? Who's going to pay for these lenses? So some quick things that I've learned. Billing the patient privately is always the best way to go. If you bill under vision insurance, you got to set up clear guidelines of what's covered and not covered in terms of materials and follow-up visits, including a time frame for the fit. I have patients sign a fit contract, and for example, it says the fit is for 3 months, and they must return to my clinic no less than 4 times within those 3 months.
Well, there we go.
Risk me
the internet.
Can you hear me?
So Dr. Richlin is having internet problems right now. So we're going to do another poll, Beth. So we're going to go back and find out how.
Can you guys hear me okay? I'm going to wait for the poll to close, but if you've used scleral lenses as a treatment in ocular surface disease and dry eye before, do you consider it a primary or last resort option? Looks like half of us have voted. And we're going to wait a little bit longer for the votes to come in, then we'll kind of continue going here. So polls closed. It looks like 80% of you use scleral lenses as a last resort and 20% of you use as a primary option. I think that's pretty consistent with what a lot of people would say about scleral lenses. They're not your go-to. First is artificial tears, sometimes occlusion, sometimes ointments, sometimes bandage contact lenses. But if you start thinking about them sooner, sometimes you can get patients happier quicker. So you just have to really look at the patient in your chair. The other thing I was going to say is that if you're going to bill medical insurance, you're going to get paid pennies on the dollar. They really don't respect fit fees of what we deem as usual and customary. They really just fit, or they'll pay you very low for your fit. So just kind of be careful there. You don't want to go into a medical fit expecting to be paid anything close to your usual and customary. So be careful when you're going over fitting and billing medically. Let's do another case example. This one is slightly different. So here's a 37-year-old male already having a history of wearing scleral lenses for keratoconus. Chief complaint, eyes are always red, vision is better with contacts than glasses, so he puts up with the redness. Pretty moderate myope with high amounts of irregular astigmatism, and he's not seeing well out of glasses. Anterior segment imaging, you can see some dense inferior corneal staining. Back of the eye is very normal. So this is a patient already wearing scleral lenses and coming in for red eyes, and the issues almost of having dry eye and symptoms like it. So how am I going to turn this one around? let's take a look at what's going on here. So this photo is taken immediately after the patient had removed the lenses. The lenses were 2 years old, but otherwise in good condition. I told him to discontinue his lenses and we would refit him a new lens. I'm taking a bit of a gamble telling a patient I'm going to do better than their last doctor. I've got to be careful. I really wanted better for his eyes, and I was going to put my reputation on the line to do it. This patient was very frank with me. He said, and he looked at me, he says, if you think you can do better, okay, fine, let's try. Having him discontinue wearing his lenses for a week so that I can start fresh with him was a big deal to him. His vision in his glasses was not very clear or, adequate for him. So this was a big deal, taking him out of his lenses for a week. I fit him in a Onefit Med Plus 17mm scleral lens, quadrant specific off the first lens. Even if I didn't need quadrant specific toricity, I wanted it there built in so I could change it as needed. And this would allow me to really center the lens that it looks like the prior fit was unable to achieve. I also went large with him, a 17.0, a feature that I believe is needed when you want to get good centration and when patients complain of red, dry eyes. So how did this look? So again, I apologize. I didn't take a billion pictures in between, but this is after 2 weeks of wearing the new lens and then coming in for a follow-up and removing it. As you can see, the eye looks much better. There's still some staining going on the eye, but this patient wore a tight lens for years, and it actually took me about 5 lenses to fine-tune this patient's fit and to help the redness go down and to get the cornea to heal. Ultimately now he appears normal. He doesn't look stoned anymore. Those are his words, not mine. He finally feels more comfortable going to work, wearing his lenses, even if it's over a Zoom call. It's just nice to not have red eyes. His vision in his lenses OU is 2015 plus. His final lenses were quadrant specific. That allowed me to center them better, to lift them up from the inferior part of the eye where his previous lenses were writing down to. And one of his lenses was a front surface toric lens. I know my Blanchard consultant will never forget this patient's name. I had to be sure we were a success. I could not fall back on my blade and not get him to be fit better than his prior lens. I had to succeed with him. My reputation was on the line and his eye health was on the line too. But getting him out of a lens that did not provide quadrant specific parameters as an option was really the Achilles heel for him in his prior lens, and that's what really enabled me to be successful in his new lens. And I was confident enough to take him out of a lens because I knew the new lens I was putting him in had every trick, every bell and whistle that was needed to get him a healthy fit. So how do I best utilize the Onefit Med family of scleral lenses? I like to really use the right diameter. We often say a few millimeters over HVAD is suffice, but I'm very picky when it comes down to scleral diameter. And it's nice to have a family of lenses that I know exactly how to fine-tune come in multitude of diameters. Like I said before, the Onefit family comes in over 10 diameters, and the Onefit Med in particular and the Med Plus come in 4, 15.6, 16.0, 16.4 for the Med, and the 17.0 in the Med Plus. But once you know how to fit the Med, you know exactly how to fit the Med Plus. So now you just have a broader parameter base for diagnostics for your diameters to fit a broader range of patients, which I like. I also use the online fit tool to help me fit lenses on eyes in conjunction with my OCT and my slit lamp imaging. Utilizing the online tools, you really get to fine tune these lenses to be healthy, and you get to fine tune these lenses and change the fit, which also changes the power sometimes, which could be advantageous. As you saw one of my first examples, changing the M, which changes the base curve, made that lens center better, but it also lowered the power, which is nicer to look out of as opposed to a high minus lens. And then ask for help. I think one of the best tools you have from Blanchard is their fitting consultants, your regional reps. You do this often, but they do it more often. It's their job to know the lenses inside out. It's their job to be good at troubleshooting, and they do a great job at fulfilling those requirements for you. So I utilize my rep as often as I needed. I'm not afraid to call her, and she has been an invaluable resource at getting better at fitting. So another case example to kind of show fitting lenses for dry eye. This particular example is one I'll never forget for my entire life because the patient actually wanted to remove the eye, quite frankly. But here's a 50-year-old female, history of a blepharoplasty 7 years ago. It left one eye unable to blink, and a history of a failed scleral lens fit. So here am I going again, trying to go after something that someone else failed to do, but I think I can do it. I think I have the right tools to do so. Chief complaint, I hate my eye. I can't see out of it. It's painfully dry. I can't close it. I use artificial tears 20 times a day without help. Pretty classic for a patient that cannot close their eye for whatever reason, anatomical or physiologically induced. If you can't close your eye, it is a nuisance. Refractive error for her, pretty unremarkable. Anterior segment on that left eye was a linear deep defect, and back of the eye was normal. So again, with my wonderfully timed photos, I did not take a photo of the front of the eye like I probably should have. I did not take a picture of the whole lens fit, but I did take a few, and I want to share those with you. So I ended up fitting this patient, a dry eye exposure patient, with a large lens. Remember, I like the larger Onefit Med Plus, the 17-0, to have a larger landing area so it's comfortable, but a larger surface area to cover more of the sclera to provide more of a barrier to dryness. I just like these larger fitting lenses. I think patients find them even more comfortable and fit well. So how did this lens look on the eye? Just to back up really quick, remember that this patient had already worn a scleral lens in the past and it failed. So for her, the fit was very straightforward. She already knew INR. She already knew how to take care of the lens and clean it. So all I had to do was get her a good fit and I'd be done. I took a step further. If this patient was going to be wearing the lens, I wanted it to be a successful fit in terms of comfort, health, and vision. I offered her monovision. I said, I can make that left eye, which does nothing for you, read for you, and then you get rid of your little reading glasses. I was trying to turn a negative into a positive for her. She didn't quite understand at the time what it was going to mean for her. So I ordered a Onefit Med 17-0 millimeter, so Onefit Med Plus, monovision fit with a goal of clear vision at near with the lens on. Pretty uncomplicated fit, and let's take a look at how it looks. So I remember I told you I didn't take pictures of everything, so bear with me here. I did take a picture of a few spots. So what we see here is the superior sclera of the left eye. I'm holding the lid up so that there's no tension on the lens and how it fits. And what you can see here is a large diameter lens. You can tell because the edge of the lens goes way out beyond the limbus. But you see a very good fitting lens, a well-aligned lens to the sclera, no blanching, no towing in, no healing in. Looks like a great calm eye there. Looks great. Let's keep going. So the bottom aspect, the inferior aspect of the lens on eye, again, looks great. No blanching, no towing in, healing in. Looks like we've nailed it. Looks like she's going to be a success, and maybe I got it right on the first try. But wait, there's more. So this aspect of the eye, her temporal aspect, has a slightly raised area of tissue. Maybe it's a pinguecula, but it's very, very shallow, but it's just enough to cause irritation. So she wore this lens in that day, and right away, even though I showed you those nice pictures of the superior and inferior that look nice, her complaints were there. They're significant. She said, in an angry tone, this is why I stopped wearing the last one. It makes my eyes look red. It gets uncomfortable. See, I told you, is what I remember her saying. She kept saying, see, I told you. Now, the wrong thing to do in this situation is agree and give up. Instead, I educated that this is part of the process, and the next lens would fit better, and her eye would look wider. I have the confidence to say that because I know the parameters of my fit set. I know the parameters of the Onefit Med family, and I know I could easily tweak one of these edges, make it flatter, and make the patient happier. Do you have that option in your fit set? Hopefully you do. that when you see a problem, that your limiting factor is not the parameters of your lens, but maybe your own ingenuity. Hopefully it's not the lens is holding you back, or you really do need a new fit set. So I took the lens off the eye. I wanted to stain. And I staining this area, you can see that it's definitely tight and abrading the conjunctiva in this one area. A few options could have been a controlled peripheral recess or a little notch in the lens to just vault and avoid this anatomical obstacle. But before I did a notch, before I did something like that, I just wanted to flatten this aspect of the lens, to flatten just the temporal quadrant. Now this is something that I can do because I'm using the Onefit Med family. I can just flatten one quadrant of the lens, and I did it. So I ordered the change to the lens as a flattening of this one quadrant by 50 microns, only 50 microns. And by flattening this edge, I was expecting good results. So much so that I ordered the lens, I shipped it directly to the patient, and I instructed her to return wearing the lens after she had worn it for a week or so, and at the end of the day, so I can really see how it looks after settling, and to get her feedback of the injection and the redness and the issues that she was having. Now the patient comes back a few weeks later, how a 50 micron change look? Now to me, I forgot, how did she look day one? I had to pull up images, glad I took them. So I'll flip back and forth for you. This was after the 50 micron change, and this was before. Now, first thing I notice is that the before image is definitely a darker image. The lid margin's a little darker, it's harder to see it. And in this image, it's brighter, so definitely a brighter white photo. But I think in both images, it's obvious to see that the injection temporal to the lens and that area blanching has really decreased in that zone. So we really were successful in flattening that zone and more properly aligning to the sclera, and now she was happy. Or was she? So instead of her being happy, because now she's wearing her lens full time, her monovision lens, don't forget that, now she's reading with it, no reading glasses, comfortable full-time wear. Now guess what her problem is? Now looking at the front of her eye, she had a different issue. She said, I thought I was home free, you know, my eye is white, now it feels good, but now after wearing it all day, sometimes I get a little clouding. Now this particular type of clouding or fogging that she's seeing is really from anterior lens deposits from her incomplete blink. So I wasn't done. Just fitting the lens wasn't enough. You have to know a little bit more to be a wholesome scleral lens fitter. And from the fit, I said, listen, there's nothing else I can do. But now here's some tricks for the front of your lens getting dry like this. And I know what a lot of you are thinking, the lens came with HydraPeg on it, so that was already something I did, and something I'm glad that Blanchard offers. And the solution for this problem came down to a couple things. Her learning how to forcefully close her eyelid to squeegee the lens, kind of a forceful blink, including the upper brow. Using off-label BioTrue solution with a wet Q-tip and squeegeeing the lens when she needed it, and proper timing of her preservative-free artificial tears throughout the day, which kind of decreased how quickly or how fast this accumulation got there. Now she's a happy camper. When I met her, she sincerely asked me, what is the process of removing the eye? Because it is nothing but painful, doesn't help her see, and she just wishes that she never had that surgery, and she now wishes that she could have never had gone through it. And now we look back and we laugh at that. I'm close friends with the patient now. She's a very strong scleral lens advocate now, and we laugh at the idea that she wanted her eye removed. So another great story, good case, and just reminds you that there's always a few things you've got to think about for every patient, and then you've got to go the extra mile to sometimes bring it home for some of your patients. So I keep talking about all these features, all these benefits, all these parameters, all these things that Onefit Med and the Onefit Med Plus family offer, and it's just so crucial. I'm a scleral lens fitter, but if I don't have a lens that will fit to my every need, front surface toric options for residual astigmatism, toric haptics or quadrant-specific haptics for better alignment and fit, multifocal options to make that patient extra happy for their reading. I didn't even get into quadrant-specific limbal zones. That's even more fancy. And those CPRs, those notches I talked about, you can even do 2 on a lens. But there's really every option that you will need going forward to fit when you use this family of lenses. The limiting factor will no longer be the plastic in your hand, but your knowledge of how to fit. And we will always be learning new tricks and tips on how to fit. Just don't let your lenses or your lens parameters that you fit with be the thing that holds you back to that success. All of these things together optimize oxygen to the cornea, and that's most important for health, because who cares if you get them to see well if long-term you're hurting their eyes. So that's why I love Onefit Med, and hopefully today you guys will think a little bit more about patients in your chairs with SPK or corneal staining that might be benefited by wearing a scleral lens for also vision, and it's a 2-for-1.